So we're going to talk a little bit about, the title is kind of generic, but I'm actually going to talk about my favorite operation, which is bypass. And it's not very well utilized and very often utilized, but this is basically what we're kind of talking about here. And so, is it a laser of some sort, or it's right here? So basically, what we're talking about here, maybe it's easier to do it this way since I got both sides. But so there is a procedure called direct bypass, Ecic bypass, and indirect. And so we're talking about extracranial to intracranial bypass. So this is just so everybody is clear on what we're talking about for the rest of the couple of 30 minutes here. This is the superficial temporal artery, and we take that and place that onto the brain. And we'll talk about the reasons for that here in a second. We can also do with that artery is just kind of lay it on the brain, let collaterals grow in, and that's also an effective way of doing this kind of an operation. So I'm going to start out with a case, and this is kind of going to follow throughout the talk. And this is a case that we took care of here. A few of you in the audience may have been involved with this, but it's a 78-year-old man who came actually to the cardiology service. Don't get that many consults from the cardiologist, but this was one. Had coronary artery disease, quote-unquote Parkinson's disease. I'm not actually sure that he ever actually had that, but and hypertension. And he basically was admitted with heart failure, and they started to diurese him. And so when they diuresed him, he started developing pretty profound, actually, left side hemiparesis, nearly hemiplegia, and some dysarthria. And this would resolve when he would lie flat in bed. And so they did a CAT scan, which is evidence here. And so you look at this and you say, well, is this an acute stroke? Is this something chronic, or what is that? We'll find out here shortly. But a couple of things you notice about this. One, this right side hemisphere is much smaller than the left. There's a lot of atrophy and things here. And then the other thing that we notice here is that this patient has actually common carotid artery occlusion. So this is the common carotid artery on the left side. This is the common carotid artery on the right side, which is occluded. And so basically they had him in bed, and every time they tried to sit him up, he became symptomatic again. If they laid him down, his symptoms would go away after 20-30 minutes. And they had to keep his blood pressure above 160. This was an MRI scan. So this picture in the middle here is the diffusion-weighted imaging. It shows acute stroke. So we would see white dots here if the patient had an acute stroke, so we know he did not. This is the T2 imaging. Again, so there's all this white stuff is spinal fluid surrounding this right hemisphere is quite a bit smaller and atrophic compared to the left hemisphere. So you can keep that in mind for later. This is the MRA imaging that shows that the carotid artery is occluded. This is the basilar artery, left carotid artery, and there's no right carotid artery here. So this is an angiogram. This was done shortly thereafter, after we got involved. And so just to show what we're talking about here a little bit, this is the aortic arch. Okay, so he's got quite a bit of atherosclerotic disease. Sorry, to this, but basically this is the innominate artery here, and you can see there's a right vertebral artery with a stenosis, but there is no carotid artery. The carotid artery should be here. There's none anywhere, so you don't even see the origin of the carotid artery. This is the left common carotid artery, and this is the left vertebral artery. Okay, so this is an angiogram with a left internal carotid artery injection. That the key points here really is that this is the anterior communicating artery, and you don't see any flow across to the other side. So you're not seeing anything lighting up here. And in a lot of patients that have a carotid artery occlusion, you would see collateral circulation around this circle of Willis that we all have. You don't see that here. This is the left vertebral artery injection. So now you start to see where the collaterals are filling in so that the patient hasn't had a massive stroke. This is the middle cerebral artery here that's filling in via collaterals from the posterior cerebral artery back here. And then you see these little vessels that are coming in and filling in the anterior cerebral artery as well. So this is kind of miserable type of perfusion that this patient has here. And it's probably quite related to why he has symptoms. Now this is the right vertebral artery injection, and the thing that's important about this actually that will play into how we treated him later is that this vessel that you see down here is the external carotid artery. And so if the common carotid artery is occluded, as most of you probably know, there's the internal carotid artery, external carotid artery, and this is what we can use to revascularize the brain for this patient. So this is the external carotid artery here, but it's not very good, and the fill of this artery is just kind of filling from these little tiny collateral vessels from the vertebral artery, and that's not going to be enough to fill the brain. So if you say, okay, well, this patient clearly has cerebral hypoperfusion, you say, what should we do for him? So we look back at what data we have available, and this is kind of the crux of the talk, really is how do you interpret data, and how do you, and believe me, I'm not an expert in necessarily evidence-based medicine, but if you look at these trials, how do you interpret them, and how can you sort of extrapolate the data to any given patient, and what does it mean for you? These studies tend to get, especially nowadays, they tend to sort of be gold. And if you really look at the numbers, you wonder, does it really apply to your patient? And for instance, a lot of this data is based on a normal distribution. All the statistics and things are based on a normal distribution, and I think kind of most of our goals in medicine is not to so much have a normal distribution, have a skewed distribution toward having positive outcomes. And so if you use the same metrics to analyze this kind of stuff with probabilities and whatnot, it may or may not apply very well. And so there were a few big studies that were done. This study was done actually back in 1985. I did studies a little bit differently back then than they do now, but this was called the Ecic Bypass trial. They had worked on this for about 10 years prior to its implementation. So they took about 1,300 patients. They randomized them to the STA, superficial temporal artery, to MCA, middle cerebral artery bypass. And so the inclusion criteria basically had to have a single stroke event within 3 months. This was relatively poorly described, so in terms of what kind of stroke event you had to have, and also what imaging that may or may not have been documented on. Cerebral angiography was not required, so you didn't have to actually prove that there was a carotid occlusion. Well, you had to have a carotid occlusion, but you didn't have to prove what kind of collaterals there were. They did, on the bypass patients, they had a patency rate of about 96%, which is quite good. And then if you look at the 30-day stroke, so I mean, most of our surgical therapies, all the spine talks and everything, when you do surgery, you're taking all of the risk of whatever the outcome is, and you're kind of squishing that into, however long it takes to do the surgery. And maybe a couple of days thereafter, 30 days is what we use for the studies. And so they looked at this, and basically strokes occurred quite a bit more frequently in the initial period, the 30-day period, in the surgical group. And then the stroke rates overall were roughly similar. They were 20 to 30% over the next several years. So there was really no difference, and people said, okay, well, they were doing a lot of bypass back then, actually, and I'll get to that here shortly. I'm going to show you all these studies, and a little bit later we'll talk about what might be wrong with them. And then, both groups were similar, but there were a few groups that fared especially poorly out of the surgical group. And this, I'm not going to talk much about this, but this becomes important when we look at who might be a candidate for this. But patients with severe MCA stenosis and with persistent ischemic symptoms after these were identified, so if people were having rapid decline, they didn't fare as well. This was another study. This was published in 2011. Actually, when I was in training, our institution was part of this. And so they took 195 patients. The impetus to this study was really just that they didn't use a quantitative method to sort of codify the hypoperfusion. So they in the first study, who knows what the perfusion was. This study, they thought, well, if we select patients based on knowing that they have hypoperfusion, they're going to fare better. And so they used PET scans for this. You had to have an atherosclerotic internal carotid artery occlusion with symptoms within 6 months, and then hemodynamic ischemia on PET scan. They looked again at 30-day outcomes and 2-year outcomes, and they terminated the trial early for futility because the primary endpoint at 2 years was 21% of the surgical group and 22.7% in the medical group, which was not statistically significant. And as you can see, the 30-day stroke rate was much, much higher based on likely strokes that happened at the time of surgery. Okay, so that was this is what we call cost. A number of the surgeons that were involved were quite experienced with this. Some were maybe less so, and we'll get to that eventually. And then one other trial, which I don't have a ton of data on because, as we'll talk about later, it's not ever been published, actually. The final results anyway, and it's never been published in English. I can't read Japanese, so it's a little bit of an oddity of this study, because this study actually looked at patients very similar to the COST trial, but the results were a bit different. But why hasn't it been published is a good question. They basically showed a reduced stroke rate in the bypass patients compared to the medically treated patients. Now, the other thing to remember about all these studies is that from 1985 to now 2018, the medical management of these patients has improved greatly. So comparing the medical management back from 1985 to what we have now is probably not very accurate. I'm going to show another case. This was a part of a publication that I wrote when I was back in Cleveland. This is a very similar case to the one we had before, but managed maybe slightly differently. A 64-year-old lady who had a left-sided weakness and basically personality changes. She was a school teacher. The imaging showed a right carotid occlusion with severe hypoperfusion. I'll get to that in a second. And basically her executive function had declined to the point where she couldn't work anymore. So she saw, this was in rural Ohio, she had seen a neurologist out there. She had this MRI scan, which this is again the DWI, shows a little bit of an acute stroke right down in here in this area we call the Central Seminole Valley. And if you look at her, this is a FLAIR image, it's not too bad, as compared to the one I showed you, the brain hasn't shrunk that much. There's some abnormalities in the same area here that would indicate chronic hypoperfusion, but it's not so bad. I think I had a couple more. Sorry, I'm going to go back to that in a second. This slide was supposed to be before that one. This is the angiogram here on that same patient. So again, this is the left common carotid artery injection. You do see some cross-filling across here. This is the vertebral artery injection. Again, you see some collateral flow here into the anterior cerebral artery. And then this is the PET scan. So you can see there's quite profound hypoperfusion on the right side, on the right hemisphere. Sorry, I'll go back to this. This is the first question. My questions don't have any right answer, really, but I just was curious how people would manage this based on the data that I just showed. Good. There's a reasonable mix there, and I think that's probably what you would find across, across a cross section. It really depends on who you talk to, and based on I think that's where also a difference arises, because based on the data I showed you, probably everybody should have picked A, in terms of treating this with medical management, because the studies that we had didn't show a great effect, but. You look at those images, you say, hey, this is pretty miserable, and you say, how can we help this lady? And so, actually, what happened here was this patient was managed medically. She didn't ever have another acute stroke event, but her symptoms never improved. So she was basically hemiparetic or hemiplegic. She had poor executive function. She couldn't work, and her imaging was repeated after 5 months. You remember the FLAIR image that I showed you to begin with? This is what the brain looked like 5 months later. So it's been eaten by a rat, basically. It's the brain just kind of disappears because there's no flow. So we wrote this as sort of a editorial, and you look at some of these studies and the way that they're done, and they may or may not apply to every patient. And then there's another study here. This actually, Howard Reichman was a guy from Indiana and subsequently Chicago that he was involved with a lot of bypass surgery back in the 70s. Learned this from one of the greatest neurosurgeons out of the last 100 years. And he was actually asked to do one of these studies and turned it down. And so this was kind of his critique of some of these studies that have been done. But these studies are very hard to do. So, if you look back at these ones, so this is the bypass study from 1985, almost 2,500, 2 times the population of the patients that were in the study were operated on outside of the study. Okay, so presumably these were the patients that were considered low risk of stroke were enrolled, but the patients that were highest risk, they were operated on outside the study because they thought that these were the patients that really needed surgery and they didn't want to enroll them. And actually back at that time, I think that this sort of bias is a little bit better now, but actually quite a few of the referring physicians into these studies, they told these centers that could be bypassed, if they didn't get bypassed, that they would refer the patients to somebody else. They didn't want them enrolled in these studies because they wanted them to get treated. And now, granted, that is a bias against a bias that these procedures are going to help without any clear knowledge, but that's kind of what happened here. And so you had two times as many patients as in the entire study that were operated on outside the study. Another thing that you could critique about this one is that there was no clear evidence of what kind of collateral circulation they had. Some of these patients probably had a carotid occlusion. They may have had an embolic stroke, and it had nothing to do with hypoperfusion at all. And that's where you come in here with, there was no objective measurements of the flow or the perfusion. These kind of scans weren't available back then. And so then you can also argue if these STA, MCA is going to provide enough flow to these patients to fix the problem. And we'll get to that here as well. This was the critique in terms of the cost study. There was a much lower than anticipated stroke rate in the medical group. So that was what I was saying the medical management has gotten better. But if you look at the other studies with the medical management, it wasn't the same. The risk reduction in this medical group was much higher than most of the other studies. So you wonder about the selection criteria at that point. They have a semi-quantitative method of hemodynamic compromise. So they looked at PET, one hemisphere versus the other, as opposed to some sort of a global or quantitative method. And then the surgical arm actually had quite higher than perioperative complication rate than you would have expected. So actually, these are all ifs, right? It's kind of like I'm a Missouri football fan. If we would have won 3 more games, we would be in the title game, right? But if the perioperative complication rate was more closer to 8%, which is what you would have expected, really, then the study would have heavily favored surgery. And so there's a bunch of ifs there. If you look at significant after 30 days, the stroke rate was much less in patients that got revascularized. This one I mentioned already. It's a little bit weird. They only published an interim analysis. They never published the final results of the study, and it's really not clear why. And it's never been published in English. The Japanese also have a little bit different technique of doing their bypass procedures. Now I'm going to go back to the initial patient that I talked about that I was taking care of here. I'll ask the same question we asked about the other one. How would you manage this? The Batman race, because as long as his head is lower than his feet, he was asymptomatic, but that's probably not a great way to go through life. Okay, good. Maybe going in the right direction here. I haven't actually presented too much data that actually says that bypass does work, but I just presented data that says that the studies maybe aren't as good as people think that they might be. So that's exactly what we did. This was a little bit of a complicated case. This is, he didn't have a common carotid artery, so typically we just take the superficial temporal artery, we dump it down to the brain. This one I actually had Dr. Fry, who's a vascular surgeon who helped out, and we took this graft here and did a subclavian to external carotid artery bypass. So this is the internal and external carotid artery here. So he actually took this graft and put this graft to revascularize the external carotid, so that we can then use that for bypass. And this worked really well. This is an angiogram a couple of days later. This shows his graft here, and it's revascularizing this entire external carotid artery. Now you can see this great superficial temporal artery here, a nice big branch that we could use. Otherwise, we didn't have a good vessel to use for bypass. This is the procedure here. So this is a small craniotomy on the right side. These are the, if you mark out that STA here, this is it. And this was the incision. And then I just have a really short, even a bad talk gets better with video, so I've got a little short video here just to show what kind of procedure this is. This is actually on the brain. This is a little small cortical MTA branch. There's little tiny branches off of this that we have to divide sometimes. So we put this background, so we can see these are actually 1 millimeter squares here. So it's a very small vessel. That's where it comes in to say, well, does it work or not? This is the superficial temporal artery here. Branch. So it's a little bloody. These patients are on aspirin and anticoagulation typically, or recently for these procedures. So it's a little more bloody than you'd like it to be. But this is now the superficial temporal artery. We fish mouth it open so that it has a little bit of room to grow, and it can supply more blood flow eventually. And we're going to take it down. We're going to sew it to that vessel here. So this is the downside, really, and this is where, if you looked at costs, now we have to block this branch off. So, block this branch off, this can cause a stroke. Ideally, in my practice, I've always wanted this to be less than 30 minutes. I think that's a good, reasonable goal. If you look back at the cost trial, the one published in 2011, their average time of occlusion was 55 or almost 56 minutes. When you look at post-operative strokes, you expect that some of those patients are probably going to have post-operative strokes. The reason there's so much blood in this field, which is not great, is just this brain was actually sunk down quite a bit from the bones. It was a bit of a technical challenge because his brain was so atrophic. It was in a big hole, so the blood was kind of collecting there. I didn't have a great way of getting rid of it, so we just had to deal with it. So basically, there's a couple of ways that you can sew these. You can sew them with interrupted sutures. You can sew them with running sutures. There's some people feel like that this will grow better. This has the ability to expand if you sew it with interrupted sutures. So that's what we did here. I don't think there's a big advantage either way, but it just happened to be easier on this particular day. But this is basically what the procedure looks like, and it's a slightly technically demanding type of operation, but conceptually pretty straightforward. And so then we just close it up. Finally, we get all the bubbles out of there. We give it some heparin. Hope it doesn't thrombose. We test the branch to make sure that hasn't included, and test the final vessel, and close it up. And then we open everything up, open the final clip there, test it with a Doppler, make sure it's working. And this is indocyanine green just to show that the bypass is flowing there. And that is it. A little bit of papaver on there just to keep any spasm out. This is a CTA about 3 months later, so this is the vessel, bypass vessel coming in. It was on two images, so I couldn't get it on one, but this is the bypass going into the brain. You can actually see the little cortical vessels filling up here. And this is him. So he's doing very well, walking around and stuff like that now. That's it. So just one more survey sort of question here, I think. There we go. Referrals will be coming without question. Oh, one more. And again, there's not any right answers to these either, I think. Oops. Okay, 95 to 5. Couple of 5 people there. There's want their brain to be eaten by a rat. And one more. Yeah, I think that this, like I said, there's no right answers to these. I was curious what everybody would think here, and I think that that is probably relatively correct. I think that that's the idea behind it, right? Is that in terms of the distributions of the population, things like that, that these apply to the meat in the center of the curve. And if you follow them, they probably do result in the greatest good for the greatest number of people. It's the patients on the tails that are the questions, you know, and what do you do with those patients? And I think that's where, especially for cerebral vascular disease, and if you look at stroke, you know, and talk about ischemic stroke today, but there's, Dr. Zacharias is quite familiar with this, I'm sure, but there are probably about 75 studies that said that, you know, interventional stroke was not very good, didn't work. Well, then all of a sudden a couple came around that it was great, and now everybody's adopted it. So, and there's a flip side as well, where you know it's hard to interpret these kinds of studies, and it's really hard to I think apply some of these statistical testing and probabilities to actual people. And so that was kind of the point, is family and kids. Thanks very much.